The implication was that all complications of type 2 diabetes are in fact genetic. Here's a paper from Martin Sipperstein at that time saying that the vascular defect is independent of carbohydrate derangements of diabetes mellitus. And in fact, type 2 diabetes was actually characterized as a mild disease. You could treat it by diet alone, and glucose-lowering agents were only recommended if people had hyperglycemic symptoms. In the early 70s, the University Group Diabetes Programme presented their results of a 7-year study. This was a multi-centre study. It was very ambitious for the time, over 1,000 patients with type 2 diabetes, in a head-to-head randomisation to a control group, which was placebo, tablet and diet, a fixed dose of a first-generation sulfonylurea tolbutamide, fenformin, a biguanide, fixed dose of insulin, or at that time quite advantaged flexible dosing regimen for insulin. The study, however, was stopped prematurely, and they ran into two major problems. One, statistically excess cardiovascular mortality with tolbutamide, and also statistically excess all-cause mortality with fenformin. So these were entirely unexpected adverse events. They generated a stir of controversy, and in fact, for the first time, emphasised for physicians, patients and regulators that there can be adverse effects as well as beneficial effects of treatment, and in fact treatment for type 2 diabetes was set back. I was fortunate to join Professor Robert Turner at his first research fellow in 1975, and at that time we were very interested in restoring normal basal insulin values in a disease which has relative insulin deficiency. We looked at whether we could do this with a long-acting basal insulin, increasing exogenous insulin, or using a sulfonylurea to increase endogenous insulin. And you'll see here from this graphic that we could restore normal glycemia overnight and reduce postprandial glucose levels, although the excursions from a lower baseline are still higher than normal. 1 year later, I was fortunate to present these data at the IDF in New Delhi. And you see on the left the Vigyan Barwan, where the data were presented, Robert and I being charmed by a snake charmer. But after the study had been presented, Robert said, well, no one is ever going to give insulin early in diabetes unless you can show that there are benefits. And a day later, he emerged with this already written, nearly full protocol, which actually translated faithfully into the UKPDS as we know it today. So just 1 year later, in December 1977, the UKPDS was launched. We now know that it's a landmark 20-year multi-centre randomised control outcome study of both different blood glucose and blood pressure therapies, and examining 2 levels of intensity for each. 5,102 patients with newly diagnosed type 2 diabetes were recruited in 23 UK clinical centres, and the study completed in September 1997. Just some pictures of the coordinating centre. Here we see Dr. Susan Manley, the biochemist for the study, Irene Stratton and the late Dr. Carol Cull, who were the statisticians, and for those of you who know Amanda Adler, a young epidemiologist who joined us at just the right time for the results to be analysed. So to remind you of the design of the trial, this was substantially larger in the end than the UGGP, over 5,000 participants, primarily randomised to conventional control with diet alone, or to an intensive glucose control programme in which the patients were then randomised to a sulfonylurea, a basal insulin, or to metformin. Now, there were constraints at that time which are interesting. We were not allowed to use combination therapy. Because of the UGGP, there was a feeling that these treatments could all be harmful. And metformin was only licensed for overweight people, so the ethics committee would not allow us to put it into normal weight people, which we desperately wanted to do. Also a sign of the times, glycemic rescue could not be introduced until the fasting plasma glucose was above 15 millimoles per litre, or there were unacceptable hyperglycemic symptoms. That would be out of kilter with today's advice, but at the time nobody batted an eyelid, and the ethics committee were quite happy with that. Robert very wisely said that we should look at the total burden of disease. Nowadays, outcome studies focus just on MACE, but actually, I think with hindsight, looking at the totality of the bad things that happen to people with diabetes, something that will be seen in the next session with the outcomes model, we ended up with 21 adjudicated endpoints, all but 3 of which are in the primary composite outcome. All of these endpoints were adjudicated by David Matthews, who was the chair of the committee, together with Tim Dornan, David Wright and Charles Fox. And that team stayed for the whole study and the post-trial monitoring. So that was excellent and gave us continuity and a guarantee that we were getting the same standard of adjudication. So let's turn to some of the findings from UKPDS. And these are many and varied and often surprising. One of the first things that we found, just looking at the people who were enrolled into the study, was that around 50% of them with newly diagnosed type 2 diabetes already had a complication. You can see 1 in 5 had retinopathy, similar proportion had abnormal ECG, there were absent foot pulses, other evidence of neuropathy, and we also had some cardiovascular issues with angina pectoris, intermittent claudication, MI and stroke. And because one of the exclusion criteria was no cardiovascular events in the year prior to enrolment, these numbers would actually be higher in the general population. So that was a bit of a wake-up call, because this was a mild disease, so why did these people have so many complications right at the beginning of their journey with type 2 diabetes? Another finding that came out way before we published the final results was the fact that hyperglycemia progresses over time in a monotonic feature in people with type 2 diabetes. I'm showing you here for the overweight cohort the mean HbA1c at entry to the study, 9.2%, dropping during the dietary run-in period to just under 7%. And then we see this rise over time. So identifying that was a bit of a wake-up call. The second surprise was that when we applied a more intensive treatment using an active monotherapy, we could, of course, further reduce the A1C values after the run-in period. But then from 1 year on, this same trajectory in parallel with the diet group is seen irrespective of the treatment used. So this was a bit of a conundrum, quite what was going on. And digging into the data we had, we'd been fortunate to measure plasma insulin along with fasting plasma glucose, and so we could use the HOMA calculator to derive a HOMA % beta value. This measures beta cell function in fasting glucose paired insulin and glucose samples, where 100% would be a normal value. The first finding was that in our patients here, the entry value on average was 50%, and those in diet, shown in the dark blue, then had a declining beta cell function over time, inexorably over the 6 years of this analysis. Adding a sulfonylurea boosted beta cell output, but then after that first year, this same downward trend continued, with an identical pattern in the overweight patients, except here, where metformin was a possible randomization, we saw an early uptick, followed then by this inexorable decline, which averaged about 4% of beta cell function per year. Another finding, which again preceded the main results, was the relationship between glucose exposure, here as updated mean hemoglobin A1c, so it's looking at the values over time for each individual in the study. And for microvascular disease, there was a very strong relationship. The incidence per 1,000 patient years went up actually 15-fold from the A1Cs in the normal range, under 6, to the highest values we saw in the study, just 11. So this gave both a very strong relationship and an indication that if you could intervene, you may get benefit. There was also a strong relationship with myocardial infarction, but here, over the same A1C updated range, there's only a doubling in risk. And we must remember that factors that affect myocardial infarction are many other than glucose and often stronger. So, a finding that surprised us, because at this time hypertension and diabetes were separate diseases treated by separate people, was an early view in this Kaplan-Meier plot that the patients in UKPDS with type 2 diabetes who were hypertensive as opposed to normotensive had a highly significant increased risk for any diabetes endpoint, in fact, a 45% relative increased risk. Now, this worried us because it suggested that patients with hypertension may get differential beneficial therapies added because people would be concerned because this became public knowledge. And that drove us to, in fact, randomize the hypertensive therapies to try and even out any conflict between blood pressure therapies and glucose. So we then increased the study size to, in fact, in 1987, we added centres to keep the power of the study intact, and the blood pressure study mirrored the glucose study. 2 questions. If you lower blood pressure or treat it to lower levels, do you do better? And within that tight blood pressure control group, was the ACE inhibitor captopril or the beta blocker atenolol preferential either for benefit or for risk? By that time, we'd also recognized that you needed combination therapy. This progressive rise in hyperglycemia meant we couldn't sit back and not treat people. And so a further 8 study centres adopted a second protocol in which glycemic rescue was allowed at 6 millimoles per litre. And then finally, in 1994, the only other glucose-lowering agent to be licensed in the last century was acarbose, and we took the opportunity, because of its postprandial glucose improvement, which we had not really been able to affect with our more basal studies, to randomize just under 2,000 patients in a double-blind, head-to-head 3-year cohort follow-up. So moving to 1998 and Barcelona, this was a meeting of the investigators. Many of you are here in the audience, if you recognize your younger selves. And in this closed meeting, which was in the hills outside Barcelona, we rehearsed the slides. That was a nightmare for me because I was the slide preparer, and 80% of the slides had to be remade in 2 days, which was extraordinary. That was done with the aid of a local chemist who could produce diazo slides from PowerPoint, and with the aid of Jenny Turner, Robert's wife, who is here in the audience today, who had a second set made in Oxford and flew out with them because we always had 2 sets of slides in case of problems. Here are the 23 UKPDS clinical centres. I'd like to acknowledge each and every one of these people who gave a good section of their life to ensuring this study ran. So, at that meeting in Barcelona, nowadays we're used to getting a simultaneous publication and a paper with a MACE outcome. We actually had 5 papers published on the same day. There were 8 in total. The other 3 followed in the weeks afterwards, in which we actually detailed all of the primary results, both the differences in strategies as well as the individual treatments. And you'll see at the bottom, the health economic analysis was also there. This was, something that the group thought very strongly, and in those days we were given 2 days to give you the results of UKPDS, 2 afternoon sessions. So let's move to those results at the Barcelona meeting. The expectations at the meeting were quite low. The study had gone on for a long time. People thought that probably this would not be interesting. And there are people, many of my senior colleagues, who went off to the museum or somewhere and then afterwards were very angry that I hadn't warned them that this might be interesting. But what was a pivotal difference was that for just under a 1% A1C difference over a median of 10 years follow-up, the primary endpoint was significantly reduced. Microvascular disease was reduced by 1/4, retinopathy by 1/5, and albuminuria as well. The one disappointment, if you like, was that the 16% relative risk reduction for myocardial infarction did not achieve conventional statistical significance. And so the paper reported, paper 33, microvascular disease is reduced by better glucose control, but not macrovascular. The metformin study also reported at the same time, and here the A1C difference was less, 2/3 of the main trial, 0.6%, same follow-up, 10.7 years, but the results were striking. 32% reduction in the primary composite endpoint, 39% for myocardial infarction, 36% for all-cause mortality. The effect size for microvascular was similar at 29%, but not significant because this was a smaller study. There were only 753 patients in this study if you count those in the control arm on diet as well as those given metformin. And many people see that as a weakness or even just talk about 342. But I'd remind you this is more than 4 times the number of patients in the STENO-2 study, which I think we're all very favourably impressed by. The blood pressure study results, again, were impressive. The separation in blood pressure was 10 millimetres systolic, 5 millimetres diastolic, and that reduced the primary composite endpoint by a quarter, highly significant. Nearly a 50% reduction in fatal and non-fatal stroke, and a dramatic reduction in microvascular disease risk by 37%, as well as retinopathy and deterioration of vision. So we now had 2 treatments in patients with type 2 diabetes that could reduce these so-called irremediable genetically inspired complications. A year later, in the ADA, Robert gave the talk and was awarded the highest medal for the UKPDS group at the Charles H. Best Award for the distinguished service in the cause of diabetes. So these results had an immediate and global impact. Robert was also honoured personally by the UKPDS centres who designed and commissioned this original painting, which is a cartoon of a beta cell. At the centre is the nucleus with the Radcliffe Infirmary, and then around that are all these granules, each one representing a centre, each one having a characteristic icon for that particular city they came in. So this hangs proudly in the unit in Oxford. But sadly, shortly after that, Robert Turner died suddenly, unexpectedly. He was at a meeting in Atlanta, in fact, working on an early version of the UKPDS outcomes model, and Robert's loss was irreconcilable for us. We remember him as a physician. He was an eminent physician and clinician. He was a major scientist. He was a colleague to many of you here and others. To me, he was my mentor and friend. And I think what's true is that many of our leading diabetes and endocrine specialists and also geneticists owe their early tutoring to Robert, who had such wide-ranging interests. But the show had to go on. Material from UKPDS needed to be analysed, and so I will highlight a few things that have occurred in this century. 2002 saw the launch of the UKPDS risk engine. We'd moved from the Framingham calculator, which just had 300 to 400 patients with diabetes in it, to now a specific risk calculator that was designed by Ruth Coleman and Richard Stevens and included 53,000 patient years of data. Importantly, this provides a global risk estimate. It's not just your glucose. It pulls together all of the independent conventional risk factors and was shown in external validation to predict the results from other studies, such as HPS and CARDS. It has value at the patient level for illustrating the likely effects of therapeutic interventions and has and can be incorporated in electronic patient record systems to provide this measure of risk for clinicians and patients alike. On the left, you see what will be released later this year, version 3. Again, this has now been updated to look at cardiovascular disease as a whole. And importantly for this calculator, unlike others, you do get confidence intervals, and you can look at the sliders as you change the values and have a discussion interactive with patients about the potential benefits for them. But what about the impact of UKPDS itself? Looking retrospectively at NHANES data in the States from 1999 to 2004, you can see that the mean HbA1c post-UKPDS, as the guidelines incorporated that information and recommended tighter glucose control, did actually result in lower values. On the right, you see the proportion with an HbA1c less than 7% increased from 37% in the last century to 57% within the first 4 years of this century. But that's just HbA1c. Here is a much later but still interesting retrospective look at age-standardized diabetes complication rates, and you see firstly the rates between 1990 and 95, stable or increasing. UKPDS is published, and we see that following that, these rates were reduced substantially. Now, we're not claiming that's causal. What happened was UKPDS set the scene for tighter guidelines for blood pressure, tighter guidelines for blood glucose, but at the same time, we had the lipid data emerging, which would have had a major part to play in this. The takeaway message is you do good studies, you get results that are robust, and you can change clinical practice. More than that, you can improve outcomes for people living with type 2 diabetes. I'll select just a couple of more things that perhaps would be of great interest. This was an early finding. This is a paper by Amanda Adler, UKPDS 64, and she was interested in the relationship between nephropathy and the risk of death. So she looked in the study at the annual progression rates from people with no nephropathy to microalbuminuria to macroalbuminuria to end-stage renal disease. Again, in a long study like UKPDS, we had the power to look at a whole range of events, including hard endpoints. And you'll see the annual progression rate varies between 2 and 2.8%. But if we look at the risk of death by category, the annual rate for people without nephropathy in UKPDS was just 1%. The appearance of microalbuminuria tripled the risk, and macroalbuminuria 5 times the risk. And finally, if you were unfortunate to get to end-stage renal disease, a 20-fold risk was apparent for premature death. Now, of course, it's well recognized. We are specifically looking at renal cohorts of patients with type 2 diabetes to see how we can minimize this really unfair increased risk. In 2006, Irene Stratton did the analysis that a lot of people wanted to know was, okay, glucose lowering is good. We see this on the left-hand side, conventional against intensive. Tight blood pressure control against less tight is better. But those people who got intensive glucose control and tight blood pressure control had the best outcomes of all. This was a significant trend. So again, an early nod to the fact that multifactorial intervention is where we need to be. It's not just about the glucose, it's not just about the blood pressure. We also need to look at the lipids, we also need to look at platelets. And so eventually we got ourselves in a position where we accepted that multiple therapies were needed for this group of patients. A couple of years later, in 2008, at the Rome meeting of the ASD, we presented the data from the 10-year post-trial monitoring. This post-trial monitoring study was actually set up by Robert and myself and the other people in the group before the first study closed. All the patients were consented. Every patient who was still alive went into this study, and we followed everybody to the end of that period, or sadly, premature death if that happened. And during this time, we did have no aspirations to control them in the same groups. They went back to usual care. Their treatments became very similar, and in fact, their A1Cs became identical. But what we see here is that at the end of the study, and this is for myocardial infarction, fatal and non-fatal, that tempting 16% risk reduction, which did not make statistical significance, was maintained despite the groups coming together, so that at the end of 10 years, there was still a 15% risk reduction, but now highly significantly, statistically significant. So we christened this the legacy effect, which is a nice word that sort of emphasizes continuing benefit, and it mirrored the DCCT metabolic memory. We were unsure what caused this effect, so we didn't want to label it metabolic, so we used the more neutral term legacy. And we're still struggling to understand what does this. I think the favorite at the moment is probably epigenetic variation with DNA methylation, but the jury's out as to precisely what does this. But we do know that early treatment gives you long-lasting benefit. And in fact, when we looked at all-cause mortality, at the end of the study, it was really not commented on. There was a 6% numerical advantage to being in the intensive group, but that certainly was not significant. However, during the monitoring of 10 years post the trial, this benefit effect size doubled to 13% and became highly significant. And when we looked at this, it's actually driven by fewer myocardial infarctions and fewer downstream cardiovascular deaths. So the question of whether glucose lowering and myocardial infarction are related in a way that's causal and can lead to a successful intervention has been vexing. After UKPDS, there were only three trials that looked specifically at the randomization to high against low glucose levels, ACCORD, ADVANCE and VADT. And I'm showing the meta-analysis by the control group, which is made up of the investigators from these 4 studies, and this is patient-level data. And what we see is that overall, there is a 15% risk reduction. It is significant, and there's no heterogeneity. The ACCORD data, in fact, is probably the most impressive. And the problem with the ACCORD data is it's always presented as increased cardiovascular death. In actual fact, they had a lower risk of myocardial infarction. It's just if you were unfortunate to have a myocardial infarction, you more often died, increased case fatality. We looked at whether we could actually measure the impact of early glucose intervention. This is a model done with Marcus Lind, looking at a single patient as a representative, 50-year-old male with newly diagnosed type 2 diabetes. And we looked at what happened if you, for the first 10 years after diagnosis, left his A1C at 8 and then reduced it to 7 for the last 10 years. And we got a helpful 6.6% reduction in all-cause mortality. But if we impose the lower A1C from the get-go, 20 years of lower A1C, then we more than tripled that risk reduction to 18.6%. Earlier you start, the greater you maximize the benefit. So let's just summarize some of the key impacts that we've been able to show you today. At diagnosis, half of patients with type 2 diabetes have complications. This led to the drive to identify them earlier, to screening, and to look at pre-diabetes in a different light. We showed that hyperglycemia is an independent risk factor for coronary heart disease, and that hyperglycemia itself was progressive, and that in turn was secondary to declining beta cell function, irrespective of which treatment was used. Improved glucose control alone can substantially reduce the risk of microvascular disease. We showed you the epidemiologic relationship, and we got a 0.25% reduction for just under 1% A1C difference. And I do believe that we can modestly reduce the risk of microvascular disease by the order of 15%. The glycemic legacy effect means that glucose-lowering therapies do need to be introduced as early as possible if you're to maximize their benefit. It's never too late, but you get better outcome if you start earlier. And foundation therapy with metformin is now standard across all guidelines because it substantially reduces cardiovascular and all-cause mortality. We also found the double jeopardy story, hyperglycemia and hypertension, the bad companions in diabetes, and that improved blood pressure control by itself reduces the risk of microvascular disease and stroke. And the benefits of incorporating this with a glucose improvement strategy give you additive benefit. We showed, but I haven't had time to give you the data today, that more effective glucose control, as you might expect, can be achieved with the earlier introduction of combination therapy. And maybe if we'd been able to do that in the study, we would have got to the results more quickly. And nephropathy, we need to remember, is a major risk factor for cardiovascular disease and premature death. So I'd just like to finish with a slide from the late Robert Turner. This he used to illustrate his 1999 Banting lecture. It's Arthur Ransom's Swallows and Amazons, and the chapter entitled, "We Didn't Mean to Go to Sea." If you don't know the story, it's about a group of children with a sailboat, and they leave the safety of a river, and they sail on the high seas. Robert and I felt the same. We started with a little study, it grew like Topsy, it became global, had a major impact. We've had 116 UKPDS manuscripts published to date, and there are more in the pipeline. So this is a legacy to Robert, to the people who worked on the study, the participants who really were magnificent, and to those of you who helped fund and support the study. Thank you.